My name is Mickey, as she's probably said twice now. And in my previous role, I was actually a director of a CDI department. So this subject is really near and dear to my heart. So I hope everyone learned something from it. All right, let's see. Here is our disclaimer statement. And it's just saying that this is intended to be a general overview and it's current at the time of this presentation. So today we're going to talk about quality initiatives that CDI specialists can have an impact on, key indicators that should be reviewed in the medical record for quality initiatives, and how to track improvement of quality initiatives over time. So this presentation is definitely not all inclusive of all the details of every quality initiative. I've chosen areas where CDI can begin to focus on quality measures, just some low-hanging fruit. And for more details, if you look in my resources, I've included lots of websites that are very helpful in getting this started. So at the beginning of the presentation, we'll really go through the different quality measures that CDI can impact. And then towards the end, we're going to talk about processes to put in place and then what tracking that would actually look like. So first, we're going to talk about hospital value-based purchasing. And value-based healthcare is here to stay. It's soon going to be the standard model under which hospitals are reimbursed. So CDI really should begin to focus shift their focus to quality measures and on the overutilization of resources. Many times CDI tend to focus solely on DRG assignment and then the MCCs and CCs, and they're leaving money on the table, and sometimes they're not getting 100% accurate picture of the patient's stay and the complications. So a lot of times bringing in the subject of quality will actually really shift the physician's mindset as well, and it changes the conversation, and it'll bring more physicians on board to align with the CDI goals. So the hospital value-based purchasing program was designed to promote better clinical outcomes while improving the patient experience and reducing costs to make care more affordable. So more specifically, it incentivizes hospitals to improve the quality and safety of care. And the ways that it does this is by eliminating or reducing adverse events, adopting evidence-based standards and protocols, re-engineering hospital processes that improve patients' experience of care, increasing transparency of care for consumers, and then recognizing the hospitals that are involved in high quality care at a lower cost to Medicare. Payments related to quality. So this program is funded through the reduction of the participating hospitals' DRG payments for the applicable year. And each hospital gets a total performance score, and that is compared against all of the other hospitals participating. And then the hospital has the chance to actually win back that reduction. They have the chance to actually receive more than the reduction, or equal to or less than if they don't meet the quality goals. So 3 measures that I'm going to talk about today in this section are mortality measures, complication measures, and Medicare spending per beneficiary. So there are more measures but I'm really just going to focus on these just for the interest of time, and that these I feel like can give CDI the biggest bang for their buck. So first, we're going to go over a few words that you're going to be hearing a lot throughout the presentation. The first is cohort, and this is the claims that are eligible for a quality review by CMS. So this is all of the claims that they will be reviewing. Inclusions are the diagnosis codes that trigger a quality review by CMS, or it could be procedure codes. So you have the diagnosis codes that are principal diagnosis that trigger an inclusion, or you could have a procedure code that triggers an inclusion. And then you have exclusion, and these are the diagnosis and procedure codes that can cause a claim to be automatically excluded from the review, even if it contains one of the inclusion codes. And then risk variables, which are diagnoses that CMS recognizes as increasing the probability of mortality or complication. So the measures adjust for variables within 12 months prior to admission. So some of these variables can include age, sex, comorbid diseases, indicators of patient frailty, anything that's clinically relevant and that has a strong relationship to the outcome of the patient. So these risk variables are really what the CDI can impact. So here are our mortality measures. You have your acute myocardial infarction, or your AMI, 30-day mortality rate, heart failure, 30-day mortality rate, chronic obstructive pulmonary disease, or COPD, 30-day mortality rate, stroke, 30-day mortality rate, and coronary artery bypass grafting, or CABG. Once the hospital submits a claim with the diagnosis, with the principal diagnosis of one of these mortality measures, CMS is going to analyze the database to determine if the Medicare beneficiary died within 30 days of discharge. So 30 days after the patient discharged, that is your window of time where CMS is looking to see if the patient expired. If the mortality is identified, then CMS will attribute the death to the hospital that reported the claim with that mortality measure. So for example, if a claim was submitted with an AMI, CMS will look at the 30 days post-discharge to see if there was a mortality, and if there was, that will be associated with the hospital that that claim was associated with. And then each discharge that's included in the mortality cohort is then risk adjusted to determine the expected rate of mortality. So CMS uses comorbid categories, CCs, to determine the likelihood of death for each discharge. And then these comorbid conditions are weighted. So some have more of a significant impact on risk adjustment than others. Essentially, they're comparing what the expected mortality rate is based on all the information they have, including those risk variables that we just talked about, and comparing it to the actual rate of mortality. So one thing to note is that the comorbid conditions that affect the risk adjustment for mortality do not line up with MSDRGs, MCCs, and CCs. So for example, like AMI, only about 25% of the conditions that are MCCs and CCs on an AMI principal diagnosis account are also CCs or mortality measures. So if a CDI is only looking for those MCCs and CCs for the DRG, they're going to miss the mark here. And that's why it's important for CDI to know which conditions will affect the risk adjustment for each of these mortality measures. So we're going to go over that in the following slides. But really, the goal for CDI is just to have a clear picture that the patient's risk of mortality, of what the patient's risk of mortality is. So if you have a patient who expired and their risk of mortality indicator was a 1, I would definitely recommend digging more into the record, because we want the risk of mortality score to show a 4, ideally. Sometimes it's a 3, but a higher risk of mortality if the patient were to expire. So we spoke about this on the previous slides, but this is the mortality index, and it compares the observed to expected mortality rates. And the observed mortality is how many patients actually expired, and the expected mortality is how many were expected to expire based on the risk-adjusted claim data. So a score of less than 1 means that more patients survived than were predicted to, which is obviously what you would want. And then a score of more than 1 means that more patients passed away than were predicted to. So a lower score is always better in this case. So we can't change the observed, but what we can make an impact on is the expected to a degree, and that's where your CDI folks come in. So here is our first AMI mortality cohort inclusions. So again, these are the principal diagnoses that will be included in the AMI cohort. So every claim that has one of these codes as principal diagnosis will be pulled for review of an AMI mortality measure. Here are the AMI mortality risk variables. So these diagnoses listed here, diagnoses that fall into these categories, will make a patient's risk higher for mortality. So these are the areas that CDI really want to focus on to capture if the patient has this. This highlighted one, history of COVID, is just highlighted because it's a new one that they added in. So CDI want to be looking for these clinical indicators, especially for these conditions. I have a little CDI tip here. It just says to look at the medication list. Is the patient taking a medication that doesn't have an associated diagnosis documented in the record? This seems to always dig up some things. Sometimes you see medications listed that are just not mentioned on the record why they're taking it. And this is always a good query opportunity. I especially see this for like psychiatric disorders, anxiety, depression, things like that. Tend to be left off of the problem list. Also looking at your consults that are ordered, why are they ordering a consult? So that would be another thing that would cue you in. So here is a continuation of the mortality risk variables. So these are the diagnoses you want to be looking for to increase your risk adjustment. Another CDI tip is, or any test being repeated without a documented reason. So remember that suspected or probable conditions can be coded on inpatient cases. So if if a physician is repeating a test day after day and not documenting why, it may be because he doesn't have a definitive diagnosis yet. But after a day or so, I would query to see what are you thinking? Are you suspecting something that can be documented? And then eventually, if it's never ruled out, that could carry on into the discharge summary, and you could pick that up. So a probable or suspected diagnosis can be coded on these accounts. So next we're moving on to COPD, and here are your cohort inclusions. And then here are your risk variables. So again, these diagnoses will help risk adjust your mortality rate. And I have a little tip here to invest in the CDI ACTAS Pocket Guide. I hope all of you have this because it's such a great resource, especially for new CDI, but even for seasoned CDI, really. It just tells you what clinical indicators to look for each diagnosis, how it should be documented, how to query for it, associated coding guidance, and things like that. And it's just a really good resource, especially when you're looking for particular things like this. So here is a continuation of the COPD mortality risk variables. You notice in here drug and alcohol abuse. That is another one that I see left off quite a bit. One thing is to look in social history for this. A lot of times this is documented in social history, but never carried to the problem list. And then again, you see psych disorders here that you want to check your meds for that. We have quite a bit of mortality risk variables that affect the COPD score. You even see like some eye disorders here and dermatological disorders. You would never think that would make a difference, but that does affect your, that does risk adjust your score. So here are your heart failure inclusions. And this is your principal diagnosis code that would affect if this claim gets pulled. So here are heart failure exclusions. So if you have an account where there is a principal diagnosis of the previous slide, but they also have one of these procedures coded, which it can be in any procedure position. It could be principal or any of the secondary. It's going to automatically disqualify this from being a quality measure. So you'll see here that it's mostly the external heart systems, heart transplants that would disqualify them from the measure. Again, here is your heart failure risk variables. And here is another CDI tip. it says check the dietary notes for the degree of malnutrition. It must be confirmed and documented by the provider. So protein calorie malnutrition, which I'm sure most of you know, is an area of OIG penalties. So this is a target area for the OIG for the last couple of years. Many hospitals have been getting dinged on this. Many times physicians and dietary are not on the same page with malnutrition. I've heard physicians say that, you know, the physician's not underweight, they're not malnourished. Well, a patient doesn't have to be underweight to be malnourished. A patient can actually be overweight and be malnourished. If you are struggling with this at your hospital, I strongly suggest educating physicians on the guidelines that dietary uses to make these diagnoses and bring the dietary notes to their attention. If a patient is taking any special supplements for malnourishment or getting some type of, you know, Ensure or something, that's all considered being treated and that needs to be picked up. So even dietary seeing them and monitoring this is considered codable. So I remember at the hospital I worked at, we had so many issues with malnutrition. We had educational sessions where a dietitian actually presented to the physicians. We had templates in their notes to make the documentation easier. So it would actually alert them that the dietitian had documented that the patient was malnourished so that the physician could remember to put it in his problem list. It's really a tricky one because if you're not picking it up and it's there, then you're not really showing the true severity of illness and risk of mortality. But if you're picking it up inappropriately without the clinical indicators, then you're at risk for OIG penalties. So it's really something you want to be on the same page as your dietary folks. And here are the rest of the heart failure risk variables. Now moving on to stroke inclusions. So this is going to go by stroke principal diagnosis, all of your stroke codes. Excuse me. And here are your stroke risk variables. Another CDI tip, renal insufficiency, always query for clarification. Ask them to consider CKD with the stage, AKI, or ESRD. You could be missing the mark here just because of the wording. So for these mortality measures, there are certain things that could cause a claim to be excluded from the measure. One of the things that could cause a claim to be excluded is if the patient was discharged against medical advice. So as a CDI, you really want to make sure that this is documented and coded appropriately. I've definitely seen where I was reviewing a chart and it seems that the documentation just stopped and there's no explanation. So we really want to make sure that our physicians document if the patient left against medical advice. If COVID-19 is present on admission, a principal or a secondary code, this is excluded from your measures. If the patient is discharged alive on the day of admission or the next day, this is going to be excluded from your measures, just mainly because it's unlikely that they had a clinically significant diagnosis. If the patient is received as a transfer from another hospital, so the patient death in this case would be attributed to the facility who transferred the patient to you. So it would not be attributed to the receiving hospital. So here are the CABG cohort inclusions, and you'll notice that these are not by principal diagnosis. These are included based on the procedure, and it can be any position, any procedure position. The inclusion codes, this is just a snippet of it. There's actually 280 inclusion codes, and then there's over 5,000 exclusion codes. So I provided the link here because I didn't want to bore y'all with 50 slides of codes, but so if you are interested in those inclusion or exclusion codes, just check out this link. And here are the CABG risk variables. Again, you'll see malnutrition here. That's a big one. And then you'll see the obesity again. All right, and more risk variables. Hypertension is another one that sometimes you see in the home meds, but it's stable, so it's not documented on the problem list. That's something else that you can catch sometimes with your home meds. And then again, the renal failure, look for that renal insufficiency to see if they are meaning renal failure there. So this is a chart that was provided by Actis as a kind of like a little cheat sheet to help CDI out. I think it's cool because everything is in one place, and you'll see like the first column kind of gives what you're looking for in the measure, and then it also gives you where you can find guidance on this. And then under the notes section, it'll give you just some little tidbits of information that could help you when you're looking for this. So like, for instance, for your AMI, your anterior wall MI is going to give you a higher risk than other locations. So you really want to make sure that that the location is documented, and then just know that if it's the anterior wall, you're going to get a higher risk adjustment. And then you'll see the last one here is the total hip and knee replacement. This is not a mortality measure, but it is a complication measure, and we'll be getting to that next. So now we're going to talk about complication measures, and the complication measure in this program is for elective primary total hip arthroplasty and total knee arthroplasty. So below in the bullet points, you'll see that these, if any of this is included with a THA or TKA procedure, then it is automatically excluded from the measure. So if you have a fracture of the pelvis or lower limbs coded as a principal or secondary diagnosis field, that's not going to count in your complication measures. A concurrent partial hip or knee arthroplasty, a concurrent revision or resurfacing or implanted device, a mechanical complication, a malignant neoplasm, or transfer from another acute care facility. So all of these will disqualify that claim from being counted in your complication measures. There are over 7,000 exclusion codes that cover all of these reasons above. So I included that list here, and you can check those out. So for your THA and TKA, these are your inclusions, your cohort inclusions, and it is based on procedure code, and that procedure code can be at any placement. It could be any procedure position. So here are your knees and your hips. Okay, so now let's talk about what CMS defines as a complication for a THA or a total knee arthroplasty. So an acute myocardial infarction would be considered a complication if it's within 7 days from the start of the admission. Pneumonia or another acute respiratory complication if it's within 7 days from the start of the admission. Sepsis if it's within 7 days. Surgical site bleeding or other surgical site complication within 30 days of the start of the index admission. Pulmonary embolism if it's within 30 days from the start of the admission. Death during the admission or within 30 days from the start of the admission. Mechanical complication within 90 days of the start of the admission. And then a joint infection or a wound infection within 90 days. So I didn't include the large list of complication codes, but it is linked here if you want to check those out. And then this link also includes a list of codes that excludes the complication from being counted. And most of the codes that are on the exclusion list, or like I saw a lot of M codes, that would be like your osteonecrosis, other types of necrosis, osteoarthritis, rheumatoid arthritis, just because these patients would be more prone to getting complications, so they're not included in the measure. So for total knee and hip complications, if a patient has an inpatient admission with a principal diagnosis code of COVID or a secondary diagnosis code of COVID, and it is present on admission, on any claim that's within the 7 or 30-day time frame, they are not going to be eligible for use by the measure. So they are also excluded. So if they have COVID after their procedure, they are automatically excluded from the measure. for these 4 complications: AMI, pneumonia, sepsis, and pulmonary embolism. And this is probably because they can't definitively say if the complication was caused by the surgery or if it was caused by COVID. So that's probably why those are excluded. Okay, so here are the diagnoses that can help risk adjust your rate and show that the patient was at higher risk for a complication. So here's a CDI tip that just says, check the BMI in nursing or dietary documentation and query the physician if the BMI is over 40 for morbid obesity. This is easy, low-hanging fruit, I like to say. Many times the providers don't document the obesity, but it does have a big impact on the patient's risk of complications. So that is definitely something that I would look for when reviewing these charts. More risk variables. All right, so now we're going to talk about Medicare spending per beneficiary. As part of the value-based purchasing program, the MSPB measure assesses payments for services per episode. So an episode is considered 3 days prior to an inpatient admission through 30 days after the discharge. These payments are price standardized to remove variation due to wage index or location. And then they're risk adjusted due to the patient health status. So this slide tells you how they calculate and interpret each hospital score. It's very complicated. I tried to simplify it here, but all you really need to know is that the part of this that you can impact is the risk adjustment factor once again. And you can justify the money that's spent on the patient by impacting the risk adjustment. So CDI can impact this through the severity of illness indicator. Excuse me. So it can also be impacted through the DRG, which most CDI are already doing. So another way to impact is through the severity of illness indicator. And this can be done through hierarchical condition categories, which also is called HCCs. And these are sets of medical codes that are linked to specific clinical diagnoses. These have been used since 2004 to help CMS to risk adjust, and it identifies individuals with serious acute or chronic conditions. And then this helps Medicare to project the expected risk of future care, the expected risk and future annual cost of care. So HCCs are based on demographics and on ICD-10 CM diagnosis codes. So they are not based on PCS, CPT, or HCPCS codes. They are for acute and chronic conditions, and similar to DRGs, they are weighted for risk value. So with your DRGs, you have your relative weight, and then for your HCCs, you have your risk value score. And then similar to DRGs, they do provide quality of care comparisons, but HCCs are much more predictive of readmissions and future costs than DRGs are. And then HCCs are additive, meaning that you can have as many per one encounter as the patient has. Every January, it is a clean slate, so you have to recode those conditions. So if a patient has COPD, every year you'll have to add back the COPD, even though it's stable, they're being treated, there's no changes to treatment, the COPD would have to be added back every year. So these are some commonly missed HCC diagnoses. You'll see below the knee amputation, AAA. Coders don't necessarily remember to pick these up routinely, or physicians don't bother to document these routinely because sometimes they don't really have anything to do with the acute condition that is going on with the patient, but they do make a difference in the patient's status. So you'll see here major depression and alcohol and drug dependence, which we talked about on the previous slides. So that's a big one. And then many codes that are not CCs and MCCs on DRGs or HCCs. So if you're only looking for your CCs and MCCs, then you could be missing out on reimbursement and not really showing the true picture of what's going on with the patient. So here are some HCC codes that are not MCCs and CCs. And here are some HCCs that specifically affect your severity of illness indicator. So they will help with the risk adjustment that the MSPB measure score that we talked about in a few slides back. So these will help to boost up that SOI indicator. And then finally, here is a link to all HCCs and their weights. And I thought this might be helpful for some people because it took a little bit of digging to find this. But I felt that this would be helpful so you could really see what kind of conditions HCCs capture. So now we're going to talk about hospital-acquired conditions, or HACs. So this is the Hospital-Acquired Condition Reduction Program. So PSI 90 measures, the patient safety indicators, provide information on potentially avoidable safety events that represent opportunities for improvement of the delivery of care. They focus on potential in-hospital complications and adverse events following surgeries, procedures, and childbirth. And one major way that a CDI can make an impact here is the present on admission indicator. So here's a chart or a little cheat sheet that ACTA actually provided on patient safety indicators. And the first column will just show you the condition and then the PSI. And it should be a present on admission indicator of no. So the only way it's going to count as a PSI is if it was not present on admission, because this is a hospital acquired condition. Your second column shows you anything that's excluded in this PSI. So that's very helpful at a glance. If a CDI is reviewing a chart, they can look at this and say, okay, I don't need to bother clarifying this, strictly for this purpose, because this would be excluded anyway. And then the third column shows you, it gives you little tips of what to look for each of the PSIs. So I thought this was really helpful. The first one is your in-hospital deaths for low mortality MSDRGs. This is where second level reviews come in. I always like to have a second level review of mortality cases that have a risk of mortality of 1 or 2 to ensure that the correct DRG was assigned and that there was no missed query opportunities. Next one, pressure ulcer. Sometimes a doc will document a different stage in the wound care nurse, and that needs to be clinically validated and clarified for the record. And then next you have your serious treatable conditions. You want to always carefully evaluate documentation for the presence of an exclusion here. Next, you have your retained surgical items. Again, POA is very important here. If they were admitted with the retained surgical, if they had surgery, at another facility and they were admitted and already had this surgical item in them that's causing the issues, you don't want that to be your hospital to be dinged for that. Next is your iatrogenic pneumothorax. Review for that it's due to an underlying condition. And then 7 is your CLABSI, that's your infection, your catheter-associated infection. For this one, any length of stay under 2 days is going to be excluded from this. Also, if you have an immunocompromised or cancer patient, they will be excluded from this measure. So you want to make sure that's documented. And then next you have your hospital fall, which results in a hip fracture. So next you have your post-operative hemorrhage. One thing to note here is that if a procedure is performed to stop a hemorrhage, that is not counted as a PSI. It's if another procedure is being done and during that procedure you have the hemorrhage. The next one is the post-op AKI, the acute kidney injury. Validate that it's actually acute kidney injury versus a chronic kidney, because the chronic would disqualify them from this PSI category. And then your post-op respiratory failure. This is one that is so tricky. We had to do a lot of education with physicians on this and a lot of education with CDI. It's pretty common to have some post-op pulmonary or respiratory insufficiency, or even to have adverse effects of anesthesia, and that's not considered a HAC. Also, if the patient had acute respiratory failure prior to the procedure and it's not due to the procedure, then it's not a HAC. So it can get really confusing. The CDI pocketbook that I referenced in an earlier slide, it really has good information on this and clinical indicators to look for to distinguish the two. And ultimately, it's up to the physician to say if this was truly a post-operative respiratory failure. Next, you have your post-op PE and DVT. This is really important to ensure your POA if it's an acute or a chronic condition, because that'll exclude them. Your post-op sepsis, you always want to clinically validate your sepsis. Your post-op wound dehiscence, remember that your external wounds are not included in this. This is an internal wound dehiscence. Accidental puncture during a surgery, that is another one that can get really tricky. Excuse me. Because sometimes a laceration or a puncture is an inherent, integral, and expected or unavoidable part of a procedure. So you should only pick this up coding-wise if this is a clear complication, and the physician is really the one that needs to make that determination. The last three here are your birth trauma injuries and your OB traumas. So now we're going to talk about the hospital readmission reduction program. And this is a program that reduces payments to hospitals that have excessive readmissions. And it's based on the hospital's performance on 6 readmission measures. And you'll see here, it's the 30-day risk standardized unplanned readmission measures listed below. And that is, you'll see some familiar ones here. One thing to note is that the readmission can be for anything. So it doesn't necessarily have to be for the AMI or the heart failure or the pneumonia. The readmission can be for anything, and the hospital will get dinged on that. CDI impact here will be your HCC accuracy, because that leads to an accurate baseline for your expected readmissions versus your observed readmissions. So your observed predicted readmissions is the risk adjusted by Medicare based on HCC. So that's your admissions that are risk adjusted. So that is really where you're going to make an impact here, is showing that this was an expected readmission. It's really crazy because only a small number of cases here over the expected readmissions can really impact your reimbursement here. So this is something to really focus on if you're over in any of your readmission rates. So let's go to tracking improvement of quality measures. So first you want to find your areas of opportunity. You don't want to start out by focusing on everything. So find your measures, your results. A lot of times you can get this from your compliance officer or your case management. I have some websites listed here for public viewing, but you could definitely use this as well. Don't try to fix something that's not broken. So just look at your ones that you're really struggling with. Next, you're going to analyze your results. This is going to be chart audits. I know this can be time consuming, but this is really going to help you to find where you need to focus your attention. When you're auditing your charts, you really want to look for patterns. Is it typically the same doctor with complications? Is it, maybe he's not documenting the whole story, you know? Maybe he's not following a recommended protocol. Is it a coder that's forgetting to pick up important diagnosis? Or maybe they're not assigning the POA correctly. You know, a lot of systems that I've seen, the POA assignment is really easy to pick the wrong, between that yes and that no, it's really easy to pick the wrong one. So it could be coder education. Is there one area of the hospital that discharges patients that seems to always have readmissions? Is it an issue with their discharge instructions or procedures? And then, you know, some of this CDI cannot impact, obviously. Sometimes it's outside of the CDI scope. But if you find the source of why things are happening, CDI can assist with the solution. And chances are there are some places where CDI can make an impact. Next is the analysis of financial penalties and the analysis of inappropriate or decreased reimbursement. This is good to be able to show the financial impact. Once CDI start working on things, a lot of times administration wants to see what the financial impact is. So that's a good thing to show on your reporting. So next is to put processes in place. And the first is quality focused CDI versus CDI reviewing for everything. And this depends on many factors, including the size of your CDI department. It might not make sense for two different people to look at the same record, but sometimes it may make sense to have second level reviews, two different eyes on the same record, because they can find things that the other person just simply missed. So maybe having one section of your CDI department that performs the DRG validation and then another section that focuses on HCCs. And then the next one is using technology to streamline processes for CDI. So some coding and CDI systems have awesome capabilities that really split out the workflow and filter by different things. So they can send charts to work lists by user. So you can send every chart that has a discharge disposition of expired could go to one CDI, and that could be like your mortality review. You could, some systems have the ability to mark where there's HACs coded. So if there's a HAC coded that has a diagnosis coded as not present on admission, it'll mark it as a HAC, and that could go to a certain work list. Maybe everything with an account with a principal diagnosis of AMI goes to your AMI CDI person. So use technology to your advantage and to streamline as much of it as possible. The next bullet is to use technology to assist physicians. So this kind of looks like using alerts in the medical record. So if a doctor documents a HAC, could you set up an alert that asks, is it present on admission? Or prompts for more specificity? Automatic linkage between provider notes and a problem list. So bringing that problem from the note to the problem list, and then that problem list following the documentation all the way to your discharge summary, so that the doctor doesn't have to remember to document it every single time that they do a note. And then problem list reconciliation process. So this would be an alert that prompts the physician before the patient's discharged, or as part of the discharge process, to take off anything from the problem list that has been resolved, to add specificity, to make corrections. A lot of times when that problem list is being used by multiple clinics and multiple facilities, all within one big health system, it can get really messy really fast. And it really kind of, if you can have that prompt upon discharge to clean it up, it really just helps with the care of the patient. And then building documentation into templates. So if the doctor uses a particular template for a certain diagnosis, it would have that specificity built into the template so that they don't have to remember everything that they should be saying about that diagnosis for a coder to pick it up. Also working with case management. So case management probably already knows your areas of opportunity. They may have ideas on how CDI can assist. One thing we did at our facility was we were having some issues with length of stay. So we started assisting case management with outlier reviews. So any chart that any patient that was there over their estimated length of stay by more than a day or so, a case manager would actually send it to a coder to do a second level review on it to make sure that it was in the right DRG and that wasn't the issue. Physician education. So common documentation challenges. Providers are reluctant to document diagnoses that they don't feel are being treated. So that is physician education. That is where your CDI need to explain that treated doesn't necessarily mean given medication or procedures. In the coding world, just monitoring a condition counts as being treated. Their daily meds that they're taking in the hospital, that counts. That needs to be picked up. If if they are monitoring anything, if they're doing lab work just to see the status of a condition, that's technically enough to pick up coding wise. And it's good to pick up because it shows how sick your patient truly is. It's using time and resources, and it's telling the full story of the patient. Also, sometimes providers feel that clinical indicators already show that it's obvious that the patient is at high risk for mortality or complications. So why do I have to document all of this? Well, CMS is not going through clinical indicators. They're only looking at the claim data. So it needs to be translated into code so that it really shows the full picture of your patient without someone actually sitting there and auditing the record. And then second level reviews. So I would say there are some types of accounts that need to be held for second level reviews, and the claim needs to be held until that second level review is done. Obviously try to do it in a reasonable amount of time, but sometimes that is better than rebilling for these accounts. So some things you can do a second level review on, or is to check for DRG reconciliation, coding, sequencing errors, looking for clinical indicators for mortality, CCs that were missed that could have been queried for, medication list review to ensure that you caught all the HCCs, especially on death charts that don't have that 4 and a 4 for risk of mortality and severity of illness. A PSI and HACRP review to make sure it wasn't present on admission. That is something that I always did for our HACs before I even added it to the HAC report that we reported out. I always made sure that it wasn't present on admission, because I found so many that it was just accidentally put as not present on admission, and that threw it as a HAC. So you definitely want to check on that. And that's something quick you can audit. And then sign and symptom DRGs. Is there a more definitive diagnosis, especially on a mortality case? So next you want to track results. And this is just a simple Excel spreadsheet that you can use as a template. And it just goes by month by month to show you how you're doing. So how the hospital is doing for these measures. So I have the measures in the first column, and then month by month. So to find the total applicable discharges, this is not going to be your total discharges for the month. This is going to be only your applicable discharges based on those inclusions and exclusions that I had in the previous slides. So it may be a little manual, but there are programs out there that can help with this. Like one program I know of is MediSolve, and they consider all factors and give you the total applicable discharges. So that might be something to look into if you're interested in doing this. And then dig deeper. So this is a deeper dive into the data. This is where you find your patterns, you know, and you can see if there's a certain DRG where this is more likely with. Can you put proactive measures in place for certain types of patients to avoid this? So you don't want to, you always want to make sure, like I said, that the data is accurate before you start doing a deeper dive into it. You don't want to waste your time doing a deeper dive into data that shouldn't have been counted in the first place. Sometimes this data, you want to bring this data to your hospital committees, especially if the issues found are outside of the scope of CDI. So this is all I have to say about that, but I just wanted to take a minute to introduce VitalWare at Health Catalyst. We offer products to help with revenue cycle processes to make them more efficient, and we've been rewarded first in class for our ChargeMaster product for 4 years in a row. So if you're interested in learning more, please check out vitalware.com. I have lots and lots of resources here. So check them out, like lots of good information. And thank you. And we will move on to questions.
Yeah, thank you, Mickey. I'm just going to launch this poll really quick that asks if anyone's interested in learning more about VitalWare by Health Catalyst. So I'll launch that. Go ahead and answer if you want. But in the meantime, Mickey can go ahead and start answering some questions. And then we'll wrap it up after that. Thank you.
All right, let's see. . How does CMS determine that a patient with mortality measures has died within 30 days? So from what I've read, they, in their system, they have all Medicare patients, and they, if the patient died within a healthcare facility, they can see that a claim was filed with the expired discharge disposition. So I am not sure if the patient, if they run some other type of system that shows them if the patient was not in a healthcare facility at the time. That I do not know, but I can look more into that. All right, let's see. Can you elaborate on coding diagnoses from the problem list that are copied and pasted into the provider note? So what I was talking about with this is that sometimes a doctor will document a note, but they will forget to add a problem that's mentioned on the problem list. And so a lot of times that diagnosis kind of gets lost in the record. And it may not be like, it's usually not the main reason the patient's there. Sometimes it's just something else, a chronic condition or something else that the patient's being treated for. But what I was saying is that some systems have the capability to detect that and to pull that onto the problem list, to ask the physician, do you want to add this to the problem list? So that's a really good thing to have, so that those things are not kind of like lost in the mix. All right, let's see. I have one last question. It says, can you clarify the fact that HCCs can derive from ICD-10 codes and CPT or HCPCS codes to risk adjustment methodologies take into consideration outpatient and inpatient encounters? So for HCC purposes, they derive from your diagnosis code, your ICD-10 diagnosis codes. So these are going to be on both inpatient and outpatient encounters, and that's where they pick up the HCCs from. So they're never going to take it from your CPT or HCPCS codes. Some other, some other risk adjustment programs may use that. I'm not really sure about that, but the CMS specific ones are only taken from your ICD-10 CM codes. One more question, and then we'll go because we're right on the hour. Can you please explain more about was it treated and explain how it doesn't necessarily mean a procedure for MESFAR? Okay, this is a great question. Anything that is monitored, anything that's taking additional resources. If you need a nurse to give that patient medication for something that they typically take at home, but they are now in the hospital and taking the hospital, that can be picked up. If you have dietary, just monitoring a patient for because they're malnourished, but they're not necessarily making any treatment suggestions at the time, because that dietitian is seeing that patient, you're using resources. So it is technically being treated. So it doesn't have to be a procedure. It doesn't have to be a medication. It can be time and effort on the part of the hospital staff. And it can be anything that affects the patient physically and affects the status of the patient. All right, I think that's it.
Okay, awesome. Well, thank you so much, Mickey, and thank you everyone for joining us. Just another reminder, we will be sending out the CEUs and the slide deck and the recording link by end of day tomorrow. If you don't receive the email, just reach out to us and we'll make sure that we get that information to you. There will be a survey that pops up once you close the webinar. If you have time to fill that out really quickly, that would be great. It's super helpful for our future webinars. And I think that is it. Everyone have such a great rest of your day.
Thank you.
Thanks.